Thank you very much. Hello, everyone. So the thing I'm going to talk to you about today is some of the progress that we've had over the past few years in personalized therapy. And really, although everybody's excited about this at the moment, it really isn't a particularly new idea, actually. So the idea for this actually came around like a long time ago, actually. It was first postulated by a German physician who was actually working on antimicrobial chemotherapy over 100 years ago, and his name was Ehrlich. And he came up with the idea of the magic bullet. Now, although he was actually focused on antibiotics, all of the drugs they had at the time hadn't been highly specific, and unfortunately were having harmful effects on the patients as well as the infection. And so he came up with the idea that perhaps that we should try and come up with some kind of a drug that would affect the infection, but leave the patient alone. So how come the idea is important for us who are interested in treating cancer? Well, the important thing is that the cancer cells aren't actually the same as the normal cells. And so if we're smart here, actually, we can find a therapeutic target which is only found in the tumor, which isn't found in the normal healthy cells. And so the whole idea is here that we come up with a drug that can specifically attack the tumor while leaving the healthy cells alone. And in theory, this should lead to fewer side effects. And really, it's actually a marked improvement upon all of the strategies that people have had before, because the central idea of nearly every chemotherapy is it's basically a series of drugs that are extremely poisonous, and they actually tend to kill all cells that are fast growing. And although this definitely has some selectivity for the tumor, which is clearly fast growing, we also have other cells in us that tend to grow extremely quickly, including the cells like the hair and the intestines and other things. And so if you actually use a chemotherapy drug on people who are healthy, it can actually have unpleasant and sometimes serious side effects. And so in 2002, there were a seminal series of experiments that were actually carried out to actually try and find if there was a unique therapeutic target in the melanoma cells. And this basically came out of a series of genetic sequencing experiments that were carried out in the Sanger Center in England. And the whole premise of the experiment is they had hundreds and hundreds of cell lines that came from cancers, and were actually trying to find important therapeutic targets in these. And here is something that you've probably all heard of. It's actually a gene called BRAF, and it happens to be show a high rate of mutation in patients who have melanoma, and it's been basically found that half of all of the patients will actually have an activating BRAF mutation. The thing that's actually interesting about it is the BRAF mutations are actually only found in tumors that actually appear on skin that have been exposed to the sun, actually. And so there appears to be some ultraviolet exposure component to this. And the reason the BRAF is important for us is it makes our cells grow extremely quickly in an uncontrolled kind of a fashion. So to explain this, all cells actually express a copy of BRAF, and the time a normal cell actually grows, the BRAF is functioning in a controlled, ordered kind of a way. And so a signal is coming through the BRAF that causes the cells to grow. If you have a cancer which actually has an activating BRAF mutation, the activated BRAF is basically functioning here as a switch. And as soon as it's on, it's telling the cells, grow, grow, grow. And so the unfortunate thing about having a cancer which has a BRAF mutation is they tend to actually grow in an uncontrolled kind of a way. However, as I explained, the BRAF is actually part of a pathway which is important for telling the cells to grow. And as soon as you have this activating mutation up here, the cells grow. And as well as actually telling the cells to grow, actually the BRAF has other effects upon the behavior of the tumor too, and in particular it can increase the period of time that the cells can survive for, and at the same time makes them highly invasive. So clearly for us it's a great therapeutic target, and it figures that if the BRAF is making the cells grow, that if we have a drug that can inhibit this, it should stop, and we should be able to shrink away the tumor. And basically, this is exactly the thing that actually happens here. And so, we actually have a series of inhibitors that actually block the function of the BRAF. And how these drugs are working here is that if you can inhibit the function of the BRAF, the cells can't grow. And here are some experiments actually that we carried out here that actually showed that if you actually apply the BRAF inhibitor here, the cells will be killed. The other thing actually which is fantastic for us is the first time the BRAF inhibitors were tried in the patients here, we found they had these incredible effects actually. So here is a patient whose tumor has the BRAF V600E mutation. You can see on the scan here that prior to having therapy, the patient has a huge amount of tumor shown here in red, and then here is the same patient here again after having the BRAF inhibitor for only a few weeks, and you can see that everything has shrunk away. So although the BRAF inhibitors alone have this great effect at first, the problem that we have is after a period of time, the cancer cells actually find a way of turning the signal on again. So somehow they're able to overcome the effects of the BRAF inhibitor and start to grow all over again. So how is it actually happening? Well, the cancer cells are kind of smart actually and have a variety of approaches to actually turn on the signal again, and it can become, because they can amplify the expression of the BRAF or have alternate approaches to actually turn on the same pathway. However, in experiments that had been actually carried out here, we actually figured out that we could actually stop this from happening by applying a second inhibitor that actually blocks the same cell pathway further down. And here is the actual experiment that was carried out here, which actually showed that if you put on the BRAF inhibitor alone here, you can see the cells are starting to grow again. If you apply a second inhibitor, it really hasn't had any effect, except if you apply the two inhibitors at the same time, you have this striking effect, and the cancer cells can't escape the effects of the first drug. And so basically through a series of experiments and trials that were carried out here, we actually found that a combination of of a MEK and a BRAF inhibitor actually has an improved clinical response. And as I explained, our institution had played a key part, firstly in experiments to actually prove that it was an approach to explore, and secondly in the actual clinical trial, which actually has led to the FDA approval of the MEK inhibitor combination. And here is actually the paper that came out that actually proved the combination had been effective. So who can actually have the BRAF-MEK inhibitor combination? The first thing is that your tumor has to be positive for the BRAF V600E mutation, and around about half of all the patients will actually have a BRAF V600E mutation. It's usually only appropriate for patients who are stage 4. And the selection of the frontline treatment will actually also be dependent on the speed at which the cancer is progressing. So if you happen to be somebody who has a fairly slow growing tumor, even if you have a BRAF V600E mutation, it may be appropriate still to have immunotherapy as your first choice of therapy. However, if everything is moving along slightly more quickly, it may be more appropriate to have the BRAF-MEK inhibitor combination as the frontline treatment. And so at the moment, our research is carrying on, and our aim for the future is to try and come up with even more highly personalized approaches to therapy that I've illustrated here. And so hopefully in the future, every time that we have a patient come in, we should be able to take a sample of it, carry out some mutational profiling, and hopefully come up with even more highly personalized strategies for therapy. And I'd like to thank you for your attention.